Hello and welcome to Opt to Thrive, episode 40, Preventing Diabetes in Midlife, How to Get Off and Stay Off That Road.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Corina Sims.
Hello. Well, we are in the absolute best part of the year, in my opinion. It is a beautiful 25 degrees today with a gentle breeze. And from my view in the sunroom, the garden is looking spectacular. I've got strawberries popping out and the kale is going crazy. I've got lavender bushes in full bloom, carnations and roses and geraniums and irises and gerberas and pig face and some things I don't even know what they're called. I've got succulents and shrubs. It's amazing. I've started feeding the birds right outside the sunroom window next to the bird bath so I can watch them. There's magpies and willy wagtails and crested pigeons and lorikeets, and miner birds and apostle birds. Yes, I do. I live in paradise. Yesterday, it was a warmer day, around 30 degrees, and at sunset, hubby and I took the kayaks down to the lagoon just behind our house, and we had a little paddle with the black swans and the ducks, and we watched the hawks try and eat some of the smaller birds, thankfully unsuccessfully. We sat and listened to, I don't know, there must be at least 3 different types of frogs down there. It's like a frog symphony. We just sat, had a chat, and then as it was getting a bit dusky, this ridiculous wind blew in. We had paddled to the other end of the lagoon, so we still had to get the kayaks back to the ute. And it wasn't overly pleasant, but we made it. Just such a beautiful time of the year. Now, today's topic was inspired by a couple of ladies that I have seen recently in my menopause clinic. They aren't regular patients of mine, but have come along, as I said, to the menopause clinic for, their various reasons. And as part of my clinic, I do chronic disease risk assessments. It's one of the reasons I started the menopause clinic, to educate women on the risks that they're now at increased risk of after menopause due to those hormonal changes, and to empower them around these risks, letting them know that they do have some power over the level of these risks, in particular heart disease, osteoporosis, so thinning of the bones, metabolic disease like obesity and diabetes. So as I've said, I've seen some women who, when I looked at their results from screening tests that they had had before they saw me, they have been, let's say, a bit shocked when I tell them that they're pre-diabetic. It's a surprise. For whatever reason, it's news to them. Whether they hadn't yet followed up the results with the practitioner who ordered them, or maybe just didn't take in the information, or maybe it wasn't phrased like that. I don't know. What I do know is that I feel pretty much the same way about this as I do a cholesterol level that's creeping up, or a bone density test that's showing osteopenia. So thinning of the bones, not quite yet thin enough to be called osteoporosis. Because all of these results, to me, are an opportunity to make some changes and hopefully prevent the chronic disease itself from ever occurring, to give the patient the opportunity to make that choice herself. That's called agency, the ability to make decisions and act independently. And I am all about agency. So then I thought there may be a few ladies out there, one of you guys, who might benefit from knowing a little bit more about diabetes, and in particular, whether they're at increased risk and what they can do to minimize the risk. And if they do have diabetes, what they can do to put themselves in remission. I think that it's news to some people that this is even possible. Before we get started, though, I think we need to make some clarifications. There are a few different types of diabetes. Diabetes is essentially a group of disorders, and by the way, the 10th leading cause of death in Australia. There are 3 main types of diabetes. The one we're talking about today is the most common form, type 2 diabetes, and it's the one that we tend to think about as the one we get as we get older. Then there's type 1 diabetes. This is an autoimmune disease where our bodies make antibodies that destroy the cells in our pancreas that make insulin, and it's the one that usually occurs from earlier on, so in childhood often. Then there's gestational diabetes mellitus, which happens in pregnancy. I think most people are aware that diabetes is a serious condition that increases the risk of a lot of things, but I just want to throw out a few pretty sobering statistics. Diabetes doubles the risk of dementia. It increases our stroke risk by 1.5 to 2 times. It's the leading cause of preventable blindness in working age Australians. It increases the risk of end-stage kidney disease by 12 times. 40% of diabetics will develop some type of heart disease, and it's the leading cause of preventable lower limb amputations. So there are many reasons it is so important to prevent getting diabetes, or if we have it already, to do our best to put it into remission, or at the very least, make sure that it's very well controlled. So how does it develop? How do you know if you're at risk? What tests do you need to have to check? How often should you be screened? What symptoms might you get if you are pre-diabetic or diabetic? And finally, what can we do to prevent it, put it into remission, or make sure that it is very well controlled? These are all the questions that we're going to look at today. Let's start with how it develops, the mechanism. One of my favorite things to nerd out on is how things happen. So let's start with the basics. When we eat our food, it's broken down in our gut, and the glucose is absorbed into our bloodstream. And then it travels all over our body. Our muscles and organs take it up and use it for energy or store it. But it can't just waltz in to our muscles and our organs. It needs a little help. This help is insulin. Insulin is what helps it get into the muscles and the organs. It's a hormone that's made by the pancreas. When we become insulin resistant, it means the insulin is there, but it's not working like it used to get the muscles and organs to take up the glucose. The elevated levels of glucose then make the pancreas think that we need more insulin. So the pancreas then works harder and harder to make more insulin, and eventually the pancreas gets a bit tired, starts to produce less and less insulin. So the blood sugar continues to increase and eventually becomes high enough to be classified as diabetes. The in-between bit is the bit that we call prediabetes. So the blood sugar is elevated, but not quite yet at the level to be called diabetes. So how is it decided when that level is? How high does a blood sugar level have to be considered diabetes? Well, one of the main things taken into consideration has to do with one of the main risks associated with high blood sugar, which is retinopathy. The retina is a light-sensitive layer at the back of our eyes. It turns light into signals that go to our brain through the optic nerve and allow us to see. Retinopathy is when there's damage to the retina. The definition of diabetes is based on a group of symptoms and a blood sugar level that has been agreed on that is associated with an increased risk of retinopathy. So why do some people get diabetes and other people don't? Well, it's a combination of genetics, age, and lifestyle. So let's break down the risk factors, which will help us understand it a little better. Adults are considered at high risk of developing type 2 diabetes if they are overweight and over the age of 40. If they have a first-degree relative with type 2 diabetes, if they have a history of a cardiovascular event, so they've had a heart attack, they get angina, they've got peripheral vascular disease, or they've had a stroke. There are certain ethnicities that are at increased risk. Aboriginal, Torres Strait Islander, South Asian, Southeast Asian, North African, Latin American, Middle Eastern, Maori, or Pacific Islander people. If they have a history of gestational diabetes, polycystic ovarian syndrome, or if they're taking antipsychotic medication. In Australia, it's recommended that we should all be assessed for the risk of diabetes every 3 years after the age of 40. And for those at high risk, they should get checked every year. Now, would you be able to feel it if you had diabetes? Or are there some things that might make you or me as the doctor a bit suspicious that you could have diabetes? Most of the time, people are not aware of symptoms, but yes, there are some things to look out for. I think the most well-known ones are urinating a lot or feeling really thirsty a lot, so drinking a lot, getting frequent infections. When a woman comes to me with recurrent thrush, vaginal thrush, one of the things that I always test for is diabetes to make sure that that's not predisposing. If you get wounds that are really slow to heal because it affects the healing process, some blurred vision that always needs to be checked out. If you get a loss of sensation, generally in feet and legs, to touch or to cold or vibration. Could be losing weight, not sure why. There's some clinical signs of insulin resistance that we need to be aware of as well. Acanthosis nigricans, this is a darkening of the skin that happens around the neck or the armpits. It might feel a little bit velvety to touch. Some skin tags, which are just benign, non-cancerous little skin growths that might be on the body or the face. Central obesity, so carrying a lot of weight right around the midsection. And then signs of polycystic ovarian syndrome, so excess facial and body hair and irregular periods. There are 3 lab tests that can be used to diagnose type 2 diabetes. There's the fasting blood glucose, so glucose levels taken after at least 8 hours of fasting. If you have a fasting blood sugar level of over 7 or you have a random blood glucose level over 11.1, those levels are considered high enough to be diabetes, but needs to be confirmed by a second abnormal reading on a separate day. Then there's the oral glucose tolerance test. This is the test that anyone who has had a baby, at least in Australia, might recall. Although if you're my age in Australia, you probably did the oral glucose challenge test, which isn't quite as severe as the oral glucose tolerance test or the OGTT. So the OGTT is when you have a fasting blood glucose test done, and then you drink a flat lemonade drink, 75 milligrams of glucose in it. And then you have to sit for 2 hours. And your blood gets tested again at 1 hour and then at 2 hours to see what your body did with all of that glucose. The old glucose challenge test that we used to do for pregnant ladies was only 50 grams of glucose, and you only had to do the fasting test and then another test 1 hour later. But these days, our pregnant girls get the full version, unfortunately. It's hard to drink all of that glucose when you're fully pregnant. Poor things. Fortunately, though, most people don't have to have the oral glucose tolerance test, or the OGTT, to be screened for diabetes. These days, we can use what's called the HbA1c, which is a simple non-fasting test. You can have it done with the rest of your blood tests. I think it's really fascinating, actually. So HB is short for hemoglobin, and hemoglobin is what's in our red blood cells. Our red blood cells live for about 3 months in our body. And in this time, there's this process that occurs that allows us to tell just by looking at the hemoglobin the general level of what the blood sugar has been over the last 3 months, over the life of the red blood cell. This result's often given as a percentage, and sometimes people get confused that it If, let's say, it's 7%, that it means that their average blood sugar has been 7. But that isn't how it works. That's like comparing apples and oranges, really. We just know that an HbA1c over 6.5% is the magic number when we're looking for increased risk of microvascular disease. So we talked about that retina, but we can also get problems with the little blood vessels in our kidneys, our feet, our heart, our brain. So we know that over 6.5% is when those complications are more likely to occur. So there's an increased risk. So diagnosis of diabetes is when that HbA1c is over or equal to 6.5%. And again, this has to be done on 2 separate occasions just to make sure that we've got confirmation. For prediabetes, an HbA1c of 6 to 6.4% is generally thought to be consistent with prediabetes. Okay, so let's just say that you are like one of these women that I've mentioned previously that's come in to see me, been really surprised that they're pre-diabetic, had no idea. Go into your doctor and you're told, what now? How can we avoid progressing from pre-diabetes to full-on diabetes? Is this even possible? I've got some good news. There is certainly a good possibility that it can be avoided. Changes in lifestyle have been shown to decrease the rates of progression from pre-diabetes to diabetes by 27 to 45%. So currently, the recommendations to try and avoid progressing to diabetes are to increase physical activity to at least 150 minutes a week, lose some weight if you're overweight, at least a 7% reduction in weight is what's recommended, increase your cardiovascular fitness, so some of that physical activity has to be cardiovascular, getting your heart rate up, and of course my favorite, resistance training. Now, there was a randomized control trial published in Diabetes Metabolism Research and Reviews that showed that supervised resistance training over 2 years significantly decreased the incidence of type 2 diabetes by 65%. So having healthy, strong muscles can really improve our blood glucose levels. And this happens by several mechanisms. So remember, our muscle tissue is a major player when it comes to taking up the glucose from our bloodstream. So it makes sense then that if we increase our muscle mass, then that's just going to enhance this capacity. Resistance training also improves insulin signaling pathways in our muscles, so that makes them more sensitive to insulin. Resistance training also improves microvascular blood flow in our muscles. That also improves the delivery of glucose and insulin to our muscle cells, so that improves glucose uptake. And what we know is that when we increase muscle mass, there is often an associated reduction in our fat. Another great reason to be lifting weights, ladies. And that in itself can improve insulin sensitivity, not to mention reduce inflammation. And both of these are helpful for glucose metabolism. So these are just a few ways that resistance training and healthy functioning muscle can help us prevent diabetes. Now, if you already have diabetes, then the question becomes, can you reverse the process? Or can you put yourself into remission? Is this possible? Essentially, diabetes can't be reversed, but it may be possible to get it into remission. So remission doesn't mean that the diabetes is cured or reversed. Remission just means that the person has an HbA1c of less than 6.5%. And this has been achieved with intensive health behavior changes rather than medication. Remission is more likely to be achieved for those people who have had diabetes for less than 5 years, and if they had a lower HbA1c when they started attempting remission, and for those not requiring insulin. In terms of those health risks that we talked about earlier, we don't have enough evidence to know how much being in remission is going to impact them. We hope that it will lower them, but We don't know for sure, so we still need to be regularly monitoring both the risk factors and the blood sugar levels in case it creeps back up again. What we do know, though, is that people have a higher chance of achieving remission if they lose around 10 to 15% of their body weight. This kind of weight loss, especially if you're on medication, really needs to be done with some monitoring by your doctor. In terms of exercise, the current recommendations for adults with type 2 diabetes are, again, that 150 minutes or more of moderate to vigorous intensity aerobic activity every week, and spreading that over at least 3 days with no more than 2 consecutive days without activity. So we need you moving regularly. At least 60 minutes of that 150 minutes needs to be at least 2 moderate to vigorous resistance training sessions. And another recommendation is to avoid prolonged sitting. So getting up at least every 30 minutes and moving around, that will really help with blood sugar as well. Regular physical activity of any kind can help improve blood sugar levels, can also decrease the risk of cardiovascular disease and overall mortality, so death from any cause. But more structured, specialized, and individualized exercise programs give even better results. So if you can get an exercise physiologist involved, that is a spectacular idea. In Australia, you can get a GP management plan, which is done by your GP, and that can help subsidize the cost. So ask your GP about it. It's really important to be safe. So if you have diabetes and you're just starting an exercise program, it really needs to be discussed with your doctor first. And of course, if there's any chest pain or shortness of breath beyond what you feel is normal for that activity, you really need to talk to your doctor about that too, given the increased risk of heart disease with diabetes. Now, for aerobic exercise intensity, you might be asking what's considered moderate and what's considered vigorous. There's a couple of ways that you can easily work this out. So using the RPE scale, so the rate of perceived exertion, so moderate feels somewhat hard and vigorous is hard. It's a bit more subjective than using the talk-sing test. So if a person feels like they're working somewhat hard, they can comfortably talk, but they can't sing, they're more likely doing moderate intensity exercise. If they feel like they're working hard and they're unable to talk comfortably, then that would be considered vigorous intensity exercise. So that's what I've got for you, ladies. I hope you got something out of it, and in particular that you need to be building and protecting those muscles, including your heart. I do sometimes forget to mention that we still need to be doing some cardio, so I hope you got that out of it too. I also just want to mention I've got heaps of fun stuff going on at the moment. I've got some free resources starting to build up. I've come up with some fun quizzes that are on my webpage, and I've put out through social media, and I've also sent some email links to those that are on my email list. One was a bone quiz, so you can see how your bone health is stacking up. And the other is an exercise quiz. So are you doing the best exercise you can for your midlife body? Couple of fun quizzes and give you an idea of where you're at. I've also done a couple of guides, a midlife reset guide and a 7-day roadmap to help you tweak your nutrition and exercise, again, for your midlife body and help set you up to shift any excess midlife weight you may have found around your midsection. So as I said, those are on my website. You may want to check them out. If you haven't joined my mailing list, I'll leave a link in the show notes. It's the best way to learn about the resources and all the other fun stuff I get up to. I'm also getting ready to do another couple of webinars soon. So webinar masterclass sessions. I'll put a link for those in the show notes as well. Thank you guys so much for joining me today. I really appreciate you taking the time out of your day. If you haven't yet rated the podcast, I would be so grateful if you could do that before you leave, and leave me a message too if you can. I love hearing from you guys. I hope you have a great week, everyone. And until then, I hope you opt to thrive.
The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at opttothrive.com and leave a comment for any subjects you would like to hear more about.